Hello, and welcome to tonight's panel discussion in partnership with ICON. Tonight, we'll look at Ireland's most commonly inherited disease with a range of speakers coming from different angles based on various expertises. Thanks to new research, we're starting to understand the challenges associated with cystic fibrosis, while providing some of the practical tools enabling patients to live longer and enjoy a higher quality of life. Tonight, we'll not only hear from researchers on the front lines of clinical trials, but we'll also hear from one representative who is living with cystic fibrosis. Before we begin, I advise you to use your phone as much as possible. Keep an eye on the hashtag and the Science Gallery Dublin, or follow the Science Gallery Dub accounts, Twitter, Instagram, and Facebook, and enjoy the event. But before it begins, keep an eye on the exits. There are the doors that you entered, and then there's also exits here and here. And without further ado, I'll hand you over to Ciara.
Thank you all very much for coming this evening. My name is Dr. Ciara Kelly. I am a doctor, a medical doctor, and a broadcaster, and I am the moderator this evening. I am in no way the expert up here. I'm just asking the questions. We're going to talk to our panelists for about 45 minutes, I think, and then we would be delighted to take questions from the floor on anything that you want to know or anything that you've heard up here over the course of our conversation, or if you have something very pressing that you want to put up your hand during the talk, I think we can accommodate that as well. Sometimes not everything keeps to the end of a conversation. I'm going to introduce you to our panelists. I'm going to tell you a little bit about each of them. They're very impressive people. Firstly, we have Bennett Broderick here, and Bennett has cystic fibrosis, and he is an ambassador and an advocate for the disease and has always been involved in advocating and in supporting others with the condition, and he has used his voice. I've interviewed him myself before on radio. He's a great speaker. He's in TY in school. I'm saying that for a reason, because I don't think people would know that, because you seem so knowledgeable and mature and all that kind of thing. And he is very involved with the cystic fibrosis charity 65 Roses, that he had to explain to me why it was called that, but he might explain to you as well. But Bennett is going to talk about, I suppose, the lived experience of cystic fibrosis. This is Professor Pádraig Fallon here. He is the Professor of Translational Immunology here in Trinity, and his research on translational immunology brings studies in the lab and also in patients with inflammatory diseases as well. And he is a Wellcome Trust Fellow in the University of Cambridge and a Fellow of Trinity College and a member of the Royal Irish Academy. He has been awarded a Doctor of Science from the University of Wales and is an opinion leader on preclinical development of therapeutic strategies for inflammatory diseases, and has made a number of fundamental discoveries in immunology. And in 2018, he was one of 3 scientists in Ireland who were ranked in the top 1% of immunologists in the world. So I think we're very lucky to have your expertise this evening, Pádraig. And this is Nicola Hurley here, who is an exercise physiology PhD student based in the School of Health and Human Performance in DCU. And Nicola, her research is jointly funded by Cystic Fibrosis Ireland and the Mater Foundation. And she is passionate about the idea, and we're definitely going to talk about it tonight, that exercise is medicine. And she aims to develop a home-based, technology-driven, CF-specific exercise intervention with the patient at the heart of all that. So that's who we're going to be talking to tonight. People with different, I suppose, takes on cystic fibrosis and somebody who has it. And what I might do, first of all, I always think it's one of the best things to do to set, I suppose, the stage for the conversation we'll have is come to you, Bennett. Can you tell people, you're 16?
15.
15. Yeah. See, I keep thinking you're very mature. What it is like in your life on a daily basis having cystic fibrosis. What ways do you have to manage it? What ways does it hinder you or hamper you? And what do you have to do to sort of cope with it?
Yeah, so I have cystic fibrosis. I was diagnosed at 19 months old. So I suppose on a day-to-day basis, it's quite challenging in terms of, I suppose we have to try to keep well and try to prevent ourselves getting infections so that we don't go into hospital. But I suppose on a regular day, I tend to do loads of different things. So I would do nebulizers. So I would do nebulizers, again, helping to prevent, again, chest infections. I also do a lot of airway clearance. Again, this is all to help prevent getting any chest infections. I suppose other things, that I have to be cautious with CF is hand hygiene. That's another big thing. So say if I'm out, even in school, touching handles of doors, they're a big thing that say, because if I touch a handle of a door and I catch something, I could be hospitalised up to 2-3 weeks in hospital with another infection. So I suppose having to do nebulizers, having to just, I suppose, keep well and just having to prevent anything happening. And I suppose winter time now is a big time for people with CF, because obviously the flu is something that I suppose we're all afraid of getting. So we always get, most of us with CF will get our flu vaccine to help prevent getting the flu. So obviously, like, if we get this flu with CF, you know, we could be hospitalised, and it can be quite bad for someone with CF. So I suppose having to just keep well, doing nebulizers, a lot of physio is a big thing.
How much of your day is occupied? Because obviously when you're on a nebulizer, you have to sit there for a while. Or if you're doing airway clearing, I mean, if you're banging on your chest wall or doing home physio, does it take an hour a day? Does it take 2 hours a day? How long are we talking about out of your day do you have to devote to the management of it?
Yeah, well, I'd say a total of, it would probably take a good 3-4 hours. That's a total of a day. When I'm well, when I'm sick, you know, it could be 5 hours, like, of just trying to do different things like nebulizers. But no, it is quite challenging, but I suppose you kind of get used to it after.
And that, you said 3 hours, say, when you're well, maybe more when you're sick.
Yeah.
That, I presume, interferes with your ability to do other things. Because if I took 5 hours out of my day every day, I wouldn't maybe be able to work as much as I would, or there are things like that. So does it interfere with sports or socialising or school attendance?
It definitely affects, I suppose, school, because, you know, having to get up earlier, of course, if I'm coughing during the night, you know, trying to sleep, I'm going to be very tired. So I suppose it badly affects school life. And I suppose that's one thing that I suppose most CF patients can relate to is, you know, I suppose affecting the school and just affecting, I suppose, everything we do is kind of CF, unfortunately, does come into a play in things like that.
And obviously, if you're off and you're home, you could probably do bits of studying still, and I get that. But when you're 15, you're in TY, if you're out of school, you're missing the banter, you're missing the crack, you're missing what's going on. Does it affect, if you are somebody, particularly a young person with CF, does it affect your social life? Because you are a little, not in every way obviously, but a little different to your peers. You have something else going on, and being a teenager and being a little bit different, that's hard.
Yeah, no, it's definitely hard. But again, I think social media has a big play in, I suppose, keeping up to date with what's happening, say, if something's happening in school, or just even, say, going into hospital, social media is a big play. Say if I have an infection, you know, my school, I'm looking away, my school use Microsoft Surfaces, so they're able to upload all the work online, so I'm able to access it. Say, you know, I'm in hospital and I can access, you know, say if they're doing English, I could see, just even to look over the work that they do is very important, just to stay in touch. But again, social media, and I suppose media in general, has definitely transformed the lives, my life anyway, in terms of keeping in
we
with
hear
people.
We hear lots of negative stuff about social media for young people, but in your case it prevents you from being maybe isolated the way maybe somebody with cystic fibrosis would have been 15 years ago if they weren't, you know, if they were in hospital or at home, they were just missing everything because people weren't texting or on Snapchat or whatever.
Yeah, no, definitely. And I think that's something that I'm grateful for, is being able to even just look over and being able to stay in contact. It's something that most people wouldn't think of, you know, when they're sick. But in my case, you know, missing unnecessary days sometimes, but missing days when I'm sick and just looking over, it's definitely helped.
It dominates a lot of your life.
It does, it definitely does. But
And have you missed, just lastly before I bring in Pork and Nicola, have you missed, Bennett, over the course of your schooling, a lot of school? You know, you said you might be in for 2 to 3 weeks at a time. That's most people, if they get, when they're in school, get a flu or something, they're out for a few days, whereas yours is longer term.
Yeah, no, I've definitely missed loads throughout the year, but I suppose that's the nature of the condition. That's another challenge we face. But no, I've definitely missed loads. But I suppose having help from my teachers and having help from the school is a big thing, something that is really helpful. So if I am out, they can accommodate me, which is really good.
Okay. Pork, let me bring you in. Thank you, Bennett. 30 years on from the discovery of the gene, was that the groundbreaking first thing that we realised that we kind of knew where cystic fibrosis came from, or potentially why we had so much of it here in Ireland?
Yeah, I think the discovery of a gene just means you've got a title. So before that, you had a condition whereas you discover a gene, you can actually assume you got the mutation, you got a title to that condition, and that's 30 years ago. And in our debrief, I actually said it was a coincidental because 30 years ago, and last week triple therapies kind of came online. I think the gene was crucial. 30 years, it's probably hearing Bennett's story so well. If he'd been born 30 years ago, his life experience would be slightly different. And what's happened is science in general, biomedical science in general, has been completely revolutionized. So, yeah, I wasn't working in science 30 years, I was younger, but anyway, I joke now when I lecture to medical students here in Trinity or scientists that things I learned in the textbook and was, taken as dogma about inflammation, the function of the lung, everything to do with CF and other conditions, that was the dogma. We now question that. There's a complete revolution in our thinking of diseases, and we mentioned cancer beforehand. The fact that now patients with cancer are being given drugs to treat inflammation, if you'd said that to me 10, 20 years ago, nobody would have taken notice of it. And this kind of realization that inflammation, which is a natural response to the body, it's natural. You need it to survive, to protect you. If you have CF and compromised lung function, that inflammation is dangerous. It can contribute to pathology. And there's this big revolution now that inflammation is a reality. New drugs, new discoveries, we can actually manage or harness inflammation to improve treatment. But your question, the 30 years ago, it just gave it label. It was then possible to diagnose. So crucially, you would actually get a diagnosis at an early stage. And the last 30 years, like I said, revolution is the word I use. And going forward, I think technology has moved so forward. You mentioned smartphones and Twitter. Science is moving at the same rate, where we work in patients, and even 5 years ago, what we could do in a patient was restricted on access to tissue or blood or something like that, and volume, whereas now it's miniaturized. So now a nasal swab, you can do an awful lot with it, whereas one time you'd be asking for lung biopsies and more invasive procedures. So 30 years was the big discovery, and it came at a very good time.
Yeah. Have we changed even how we view it insofar as, I suppose in a very basic way, when we think about CF, obviously it sort of thickens secretions and it affects your bowel and it affects your lungs. And treatment used to be sort of focused on what it did, but now we're kind of focusing on what it is. Do you know what I'm asking? And that's almost a new way of looking at how to treat, not just, I suppose, but I suppose immunotherapies, immunology, gene therapies, all of those things have changed how we interact with major diseases. We don't even almost view them the way we used to view them.
Yeah, I think penicillin was discovered and it was just tested because it was discovered and it was just tested and it worked. It worked. Nowadays, a new drug comes along, a new intervention, we know so much more about the condition. So whether it be lung specific or gut specific, and I get the aspiration, which is the buzzwords, is personalized medicine. So we all, your genome's going to be sequenced, your bacteria will be sequenced, they'll take biopsies to sequence specific cells' functions. So this personalized medicine, or we call it stratify people. So 30 years ago, a person was CF, then it became a person with the delta mutation, then it came ultimately the other mutations, and the big advance is, I think Ciara, as you said, is the known disease. Quite often it takes a new drug to stratify. So you develop a new drug and it works very well in cells or functional assays, and the expectation is that in a cohort of patients, you treat with this drug and they should respond. And I always say when we see clinical trials data and the focus is on the cure rate, so 20%, 30%, the responders, and sometimes it's the ones that don't respond, maybe not right away, is the most informative. So suddenly you find out you've got 100 patients with a drug, 40, 50% response rate, which is tremendous, and you probably focus on the success. Sometimes trying to understand quite basic questions, why do those individuals not respond to that drug? And hence with CF, the different new drugs, potentiators, it's actually finding out, actually, the reason why these patients don't respond is their lung cells work differently. So it's trial and error. Unfortunately, that's the reality of modern medicine, but it's more informed.
Yeah, we're not stumbling upon things really. There's a hypothesis there behind driving the research. Just, you mentioned drugs, and I want to bring you in, Nicola, I really do. But you mentioned drugs, and obviously we've heard quite a lot in the media of drugs like Orkambi and drugs, and talking about getting access to them or not having access to them and the costs of them. Just for people sitting in the audience, it's a lovely idea to suggest that everybody who is sick with any given disease should have access to every drug that's available. In practical terms, that's not what happens, and can you explain to people why it's not what happens, about the, I suppose, the limitations and the funding and the financing behind health economics and where we go with new groundbreaking treatments?
It's a long journey. It's simply a long journey. Some scientists in a laboratory or team, they have a hypothesis, they have an idea. They might get lucky. Some of the drugs were actually mistakes, serendipity. But the journey between that person or group or team finding out a cell works slightly differently, something very fundamental, to work out the mechanism, the process, how that goes wrong, to then work out how you can change that. You know, the new triple therapies was drug screens. And, you know, even in my own laboratory, I like to say I get lots of good ideas, they all work. My lab is full of lab books. We record diaries and stuff like that. My lab is full of books from PhD students, postdocs, and a large lot of them is really good science, but made discoveries that never went anywhere. Now, this is in the laboratory, this is the pre-stage. For then a company to take on, if it's a patent, an early stage patent, for a company to take on and invest in drug discovery, drug development, where you've got huge teams, multinational, and they'll have lots of failures. That's the reality. You know, you have to have failures. It'll take years. It is very expensive. And sometimes you focus on the cost of getting a new drug, which can be exorbitant, you know, to get a but I'm trying to defend the pharma sector here, but just trying to explain that you focus on their success, but not all the attempts that fail. So I engage with companies, I do consultancy, I have meetings, and you're in the room with them, and they've got really excellent research, tremendous research, you know, patient-focused, and they've got various strategies developed. And I go back a year later, and if they've got 10 strategies, they're down to one because they didn't work. It's a very long process, and success is based on failure. So a lot of effort is done, and expense, and people's careers. And the failure is just simply, you can have the best science in the world, and quite often, until you actually go to, and you can go through cell lines or animal models, until you actually go to a patient, because we're complex. You know, humans are complex. We're all very different. You know, the CF, there's 2,000 mutations, etc. And until you actually roll out into patients with the best science in the world, we realize how little we know. Hence my analogy first that it's not the 40, 50% that respond, it could be those that don't respond. And with the triple therapies, you know, the success of them and projected success, maybe those patients that don't respond could inform on other mechanisms. So it's a very expensive process. I think you're right, the aspiration that such drugs should be available, I think that's commendable, that's what we'd like. But it takes time, and it's costly, and it's a commercial process as well.
It's difficult. Yeah. Nicola, when I was talking to Pork there, I was saying how we almost view CF differently than we used to. We don't just view it on how to work on the chest symptoms or the bowel symptoms. We view it as a condition that maybe could be moderated in some way by different types of therapies. But of course, people like Bennett and other people who are living with the disease have all the issues of the chest, have all the issues of the bowel, have all the issues that hold them back and make them unwell. Your whole hypothesis of your physiology PhD is around movement being medicine and exercise being medicine. What role does that have in CF?
I suppose there's several studies that have kind of shown the efficacy of exercise and physical activity with respect to cystic fibrosis for a multitude of things, such as, you know, improving aerobic capacity, breaking the vicious cycle of physical deconditioning, you know, improving peripheral muscle strength, especially in the road to transplant, further down the line. It kind of improves outcomes post-transplant, which is a major part of what we're doing. And then again, it slows the annual rate of decline in lung function. So there's a multitude of benefits of exercise. And I suppose what we're trying to do is we're trying to figure out the role of an exercise intervention in trying to incorporate physical activity and exercise into everyday life.
When you say it like that, it sounds like a given. Do you know what I mean? Obviously, your muscle function is better. Obviously, your lung function is better, and your lung capacity. You know, I remember when we were medical students, we were always sort of taught that lungs are a bit like bellows, and the more you worked them, the better. And I've kept a lot of that very basic physiology in my head because it's a really easy way to view it. But if you don't work parts of your body because they aren't easy to work because you're not feeling well, then they do decline. And have you developed a targeted approach to what people should with CF be doing to maximise, I suppose, their wellness or kind of stay on the plateau of wellness rather than dipping? What you heard what Bennett is doing 3 hours a day when he's well. It's a lot. And to ask them to do more is also a lot. But what would you recommend people did?
So what we've done is we've contacted a number of patients with CF, and we've had in-depth discussions about motivators, barriers, to see kind of what they like, what they dislike. We want to build on the facilitators and the motivators to enhance enjoyment, enhance adherence, and kind of diminish the barriers and kind of minimize the challenges with respect to physical activity and exercise. So we want to move away from the one-size-fits-all approach, the rigid kind of structured prescription of exercise, and we want to change it and kind of individualize it, and each individual person that we're dealing with will have the flexibility to decide what they want to do once they are hitting the exercise guidelines that have been developed by the European CF Society.
I would imagine, and I have no stats to back this up, but I would imagine that should it be made available to patients, for example, with CF, to have access to things like personal trainers, that actually would probably be cost effective, because if you could stay well and if you could stay out of a hospital and if you could do all the stuff that would keep you fit and well for longer, overall you would probably cost the health service less, because you know, when you're in hospital for 3 weeks, if we were running up a bill, it's so expensive to be treated in that way. So if you could be prevented from being in that position, that would be a good thing. Have they come on board with that idea in the likes of the HSE or the Department of Health or those types of things? Are they on board with exercise as medicine?
We haven't, because research is so scarce in this area. You know, prior to the discovery of the gene, there was as much research done within those 30 years as there has been in the 30 years since. So we're kind of working at a baseline level at the minute. But one of the research studies that we've done in DCU is to look at healthcare professionals' knowledge around exercise, look at their level of education that they've received, and then again their application of this knowledge within practice. And what we've seen is, you know, there is a big gap in the education received by healthcare professionals with respect to exercise prescription. So we're hoping to develop a CPD training course, an accredited course for healthcare professionals to kind of educate on a wider scale about the importance of exercise as an adjunct therapy.
Yeah, not just to CF. I mean, I think there's proof in so many areas.
I think the concept of as prescribing exercise in cancer, surgery, survival, it's, you know, the studies on, there's a lot of data in the public domain. The studies actually in Dublin is that having a prescribed exercise program pre-surgery and after surgery can improve the outcome. And there's some really exciting science about it, because when you look at modern diseases, or disease in general, we always think in the context of Western societies, because that's what we treat in modern medicine. We probably ran from saber-toothed tigers when we were evolving 1,000 years ago, whatever, and now it's emerging that the muscles that are driven by exercise with these cytokines factors, which improves your well-being physically. So if you're treating, making some exercise, you improve in lung function as well, obviously. As we discussed, Nicola, it actually is a feel-good factor.
We are slow to keep up with this, the poor, aren't we? Because, I mean, we know, for example, in cardiovascular conditions, they do actually prescribe cardio rehab post a heart attack or what have you. So they'll actually bring people in and put them on treadmills and make them do exercise. Not make them, they don't like beat them up or anything, but they do encourage them and they facilitate them, and they have the idea of a cardiac gym for people. But it isn't, we need to move away from it as just the idea of a cardiovascular situation, because you say cancer, but mental health as well, and CF, and there's loads of conditions that we know benefit from it. Arthritis, tons of things are benefited from movement and exercise. But lifestyle medicine, the idea that you would have an intervention in somebody's life in terms of their exercise or their diet, is something that we've been slow to embrace in maybe the medical or the science fraternities.
I think Nicola makes the case that basically it's health economics. So if the hospital care, your example there, if you could actually make the case, again we're going to the hospitals, the HSE, the government, that you decrease the cost and improve recovery, hospital stays, medication, by having a physiotherapist working with a patient for any condition actually, but very particular for CF because that it's early in life, and you can change the quality of life. The economic story is probably the one that will actually get that support.
Yeah, sadly or rightly or wrongly. Bennett, when you obviously engage with the team that look after you and look after your health, do they emphasise things to you? Has it trickled down from the lab and from the PhD to the actual patient? Is exercise and the value of exercise, are things like that emphasised to you?
Oh, definitely. Like from everyone, from the consultant down to anyone who's working in the multidisciplinary team in my hospital anyway, are very passionate. Exercise will, improve your outcome, will improve, and even the physios in there, they're all good at, I suppose, setting out your own personal guidelines, what you can do yourself. But I do think it's something that is needed wider, like the other hospitals need to kind of, I suppose, re-educate the staff on the importance of exercise in terms of, I suppose, different, like between dietitians. Everyone, I suppose, knows about it, but I suppose, again, they're not very confident in it.
Yeah, and that's, I suppose, an issue. And do you engage, what kind of exercise do you engage with? Because I would imagine maybe running for 90 minutes in a soccer game mightn't be ideal, but there are obviously other exercises that you could do. And is that made easy for you to find exercise, or you just told go for a walk? How does it in practice work?
Yeah, well, I have an exercise bike at home, so I would try my best to use that as much as I can. Also, I play tennis. I play tennis a lot, so I suppose those things are things that help to prevent us getting infections. Even going for a walk, brisk walking, that really helps. Any form of exercise for anyone with CF or for anyone in general, is good. But I suppose one thing living with CF is we don't actually do exercise for fun, like I suppose most people would. We're doing it, supposed to keep well. In reality, we're doing it to, keep going. So, but no, it is important that I suppose that we do it. It's something.
Yeah. For to bring you back in, one of the things we wanted to talk about this evening was, I suppose, advances in treatment. Where are we going? We've mentioned drugs, we've mentioned transplant. Where do you see the thrust going forward for somebody like, Bennett is young and that's wonderful, but we used to talk when I was in medical school, which is a while ago now, but we used to talk about cystic fibrosis only being a disease in a way of young people because the life expectancy back then was much lower than it is now. Whereas now we see it very differently because people, we used to talk about the fact that people with cystic fibrosis maybe probably wouldn't go on to become parents and because they weren't going to I hate saying this in front of you, but this is a while back now, live long enough. Whereas that's gone now. People are living much longer, much fuller lives. Where are we going with treatment?
I think the treatment and management has improved, which affects life expectancy, but also quality of life.
Yeah.
So it's not just life expectancy, the quality of life.
It's not just length, it's quality.
There's wonderful new drugs coming out there. They're very effective, not for all, which is, they'll depend on mutation. There's very good drugs coming out there. But where it will go is that 30 years ago, you went from CF to a mutation, then you responded to a certain drug. So you're basically channeling down. And it's down to treat the individual, not the disease. So you treat CF, the disease, but you're actually treating an individual, and every individual is unique. That specifically, the genetics are unique, but even the lifestyle. Everybody's got different lifestyle. Their genetics is their family genetics, which might have predisposition to other conditions. So it's treating the individual, And where it's going to go is that, at early diagnosis, you'll be sequenced, the gene will be identified, that'll inform on treatment options. But probably 30 years ago, the aspiration was actually with gene therapy to correct the genetic disorder or to treat the gene that was mutated or the type of mutation. And the future is you treat a individual with a mutation or mutations that also has a different microbiome in the lung. So that actually the microbiome, the bacteria in the lung, again, I was 20, 30 years ago, I was taught the lung was sterile. We had this idea that lung was sterile, you had cilia or whatever, but it was effectively sterile. Now it's similar to the gut, it's got its own microbiome that lives in there, which is distinct to certain diseases. So you'll be treating a genetic defect, but also an individual, which is the individual with a distinct microbiome, possibly distinct metabolism, again, how the gut operates, how it functions, and distinct gene modifiers. So other genes that can impact on that condition. So it'll be personalized to that individual. Now, it's a reality. So again, in other conditions, cancer, allergies, this is coming into its working. So it's not just prolonged life, it's the quality of life, but also it's that capacity to have tailored treatment for the individual. Because again, I mentioned we're all very different, and that's what is the aspiration. We're getting closer. I think many conditions now, you were diagnosed with a label. Unfortunately, you get given a label, and then nowadays you go on Google, which probably is not very informative.
It scares the living daylights out of you as well.
But you get a label, whereas now, when you diagnose, you get a label, they'll have a genetic explanation for you. They won't have to test drugs to find out what you respond to. Because classically, they try the best available therapies. Now there's more in our armory, I've used that word, the triple therapies, double therapies, there's more drugs available, more types of drugs. But quite often you'd have to test a drug, the best drug option, and it will work with some individuals, you have to modify it, and there's a kind of an evolving development of a management for the individual, which can be very successful, but will impact on the quality of the life. That should be shorter.
I presume, because you're talking about the microbiome, and we hear an awful lot more about that nowadays for lots of different things, I presume there's probably a degree of overlap between the research that's going on CF and other conditions as well, because people are all focusing on the same modalities of disease now.
The microbiome is very common, and the best study from a group in Israel, one of the leaders in it, and it's one that I always remember, is that they're scientists, they travel a lot, so they done their microbiome, which is their fecal microbiome, before they went to a conference, and they flew off for 2 or 3 days and got jet lagged. So they went long haul flights, came back, and then they studied it, and basically their gut microbiome dramatically changed from jet lag. So it wasn't something fancy or whatever, but just simply jet lag, which is it's stress, so it's stressful. Your circadian rhythms, everything's changed, the melatonin, etc. So that just thing, flying on an airplane, which is very unnatural for us, but jet lag exposure, that has just changed your intestinal microbiome. So you just imagine if you take a drug that has effects, if you're managing a disease and your microbiome's changing. So, there is new drug approaches, but it's just this idea that the individual has multiple parts of that. And you refer to, the bowel, the lung, other effects, the effects of exercise, and it's treating the individual holistically.
Could you see a time, Porg, where, for example, we won't need transplants anymore, that the transplants, which are currently something that obviously happens in CF, and obviously other reasons too for transplants, but in terms of CF, where we wouldn't be using organ donation because we would be able to, I suppose, intervene in the disease in less invasive ways?
Yeah. I'd like to say yes, but I think just the reality that, because again we're so different, that there could be some individuals that our best treatment options at that time may manage the condition. So the question is, are we going to cure it or are we going to manage it?
Yeah.
And, maybe 20 years ago, cure was, for many diseases actually, the medical profession aspired to cure. We have had tremendous successes, but I think now it's management successful management to prolong and have a quality of life, transplantation may still be an option, despite the best efforts. But I will clarify that, 15 years ago when you were born, if you were born 15 years before that, the way you've been managed has completely changed. I don't doubt within 5 years it's going to change again. So it's very positive, but we have to be practical that we're managing the condition at the moment very successfully, I should add.
Nicola, just on the idea and around things like transplantation, for somebody who is going to have a transplant, how important is exercise? Because I would imagine if you're going for such major surgery, optimizing your fitness, optimizing as much of your physical health as you can before you do that is key. Is there targeted approaches to exercise pre and post transplant and those types of things? Are we getting down to that level of I suppose, disease specific exercise programs?
There are criteria for transplant assessment, and the journey of the transplant exercise is a crucial component of that. In Ireland at the minute, we're doing the best we can, but we need to lead in this, as we have the highest prevalence in the world. We need to be leading in this field. But countries like Canada, the States, even Germany, they are doing rigid exercise, kind of not programs, but structured exercise for people in the lead up to the transplant, so the transplant journey, to improve outcomes afterwards. And that's kind of the fundamentals of what we're trying to do, is to improve post-transplant outcomes, and also prolong the time that a person has to, until they have to get a transplant, through exercise. But, in Ireland, there's 55% of the population with CF are over the age of 18. So
which is a great statistic.
We're doing really well, and it's an exciting field to be a part of. But again, I think exercise is really important now more than ever, because we're going to start with the drugs are fantastic, and exercise as an adjunct is so important to address comorbidities that will come down the line. Cardiovascular disease, cancers, diabetes is already related to cystic fibrosis. So I think having exercise when you're well, when your lung function is high, when you're at optimal function, I think incorporating exercise at that stage is really important to then, kind of prolong the time that you have before you ever have to go for a transplant assessment. We're trying to keep as well as we can, and I think exercise is a crucial part. Are you
pushing an open door nowadays? Because I know from my days as a doctor, doctors kind of like to be able to write a little prescription and hand you something, bit of paper, take that pill 3 times a day, you'll be grand. Prescribing exercise as medicine, prescribing it as part of your treatment, it's not as certain. It's not as black and white for the, say, the medics who are involved in the care. I can imagine a time when it was, because of the fact that it wasn't as easy perhaps to do, that it could have been dismissed or rubbished in a way. But we have moved in our mindset. We've moved in terms of the evidence we have, and even as people, I think we all kind of recognise how holistic we are and how important our lifestyle is to our health. Is it an easier sell nowadays, exercise as medicine?
It is and it isn't. I suppose in Ireland we recognise it, but we're, as we found, not prescribing it to the level that we could. And there's a quote that my supervisor loves to say all of the time about, if all of the benefits of exercise could be packaged into a single pill, it would be the most widely prescribed pill worldwide. And that's something that's going to be really important as, CF progresses and it shifts from being the childhood illness to, not fatal illness anymore. It's more of a long-term treatable condition, that we incorporate exercise and we're able to, control these comorbidities. And then with that, the education will increase and we'll be able to prescribe on a more formal and educated platform.
Bennett, when you hear all this talk, and I mean it's hard in a way to hear your health in effect, because you are someone with cystic fibrosis being discussed in sort of very black and white, third-party terms almost. But do you know where you're going on your journey through treatment? Obviously, we're talking about management and we're talking about we used to talk about cure. There is no cure, but management has changed so much that quality of life and all that has improved. Do you know, is it said to you by consultants or whoever on your multidisciplinary team, is it said to you, do you know, Bennett, we would see that in 5 years we'll be doing this and we'll be doing that, and we, you know, where we go from here is this? And do you have I suppose a path mapped out for you, or where you're going, or is it more ad hoc than that?
Yeah, well, I suppose it's more, I suppose, personalised. So again, I suppose it's depending on the patient. You can't really, like, I suppose, say to everyone you're all the same, like 5 years' time this will happen. So I suppose we just take every day as it goes, I suppose, in terms of, I suppose, like with the new CF drugs, that's giving hope, but obviously there's all the other factors that we have to be thinking of, like transplant is a possibility, and I suppose we don't shy away from that. That is something that could happen, but I suppose we don't say, look, this is going to happen in 3 years' time, or, you know, you're going to, I suppose we just have to take every day.
Depends.
Yeah,
Yeah.
it definitely depends on.
And how do you
everything.
feel, because there's an element then of living with some uncertainty, because you know, and living with uncertainty can be challenging if you don't have a roadmap as such. Is that okay with you? You'll roll with it whatever way things work out, they work out? Or would you prefer somebody to say to you, do you know what, Bennett, we'll be doing this, 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 and this in this order?
Well, personally, I think for myself, I'm happy as how it's going. Like, I suppose because I know what the future holds in CF. For myself, I know like what the path could lead to, but I suppose just how it's going at the moment is the way that, for myself anyway, it works well. So, but again, everyone's different. Some people like to sort of plan their life and plan, but again, it's a hard disease to say 5 years' time. Like 5 years' time, there could be a cure. 5 years' time, you know, you don't know what could happen in the future. So I suppose the uncertainty is something that you just have to live through, I suppose, and something you have to learn to cope with. And that's what I try my best to do, I suppose.
Porg, we always talk in the Icon series about clinical trials and about kind of groundbreaking stuff. Ireland, obviously, a high level of gene carriers for CF, ideal in a way to be doing clinical trials here. Are we seeing groundbreaking clinical trials here? Are we seeing enough of them?
Yeah, I think there's increased uptake because we have a cohort of patients. The two companies go with cohorts of patients. Yeah. So the trials are coming through, and again, internationally, I think all these developments are coming through. I think Bennett's hit the nail on the head that, you know, the 5 year, there's lots of promise, which there is, and, you know, it is positive. So I can see successes, but is this thing about cure, which was originally perceived, is this still possible? You know, genetically, there's new technologies. Hemophilia, a condition that was revolutionized again with the discovery of plasma-derived factors. So gene editing is now working on that. It's a reality, so trials are going on in that. So, you know, there is these potential, there's trials running in Ireland, you know, clinicians are heavily involved in it, and it's a large international effort. I think with all the trials, it comes down to the individual, and you just keep coming back that you run it through a trial, and if it's an Irish cohort, it's particularly attractive because of the genetics of Irish people. But you could have a result from a different geographic cohort. The mutations could be the same, and they should be transferable. And it's just time. It's just, you know,
time and money, I would imagine.
Time and money, and managed expectation. I think there's an element of managed expectation. Bennett actually addressed that, you know, positive, very exciting, but just the realities of developing a new drug to treat everybody, opposed to a drug that can treat a condition. It's those that may not be treatable with the drugs that are out there. Yeah.
Okay. Because we would love to take questions from the floor as well, but before we do, Bennett, I know you've done lots of active fundraising and all that, and CF Ireland does have a big fundraising day coming up in December. Do you want to tell people about it?
Yeah, so in December, CF Ireland, on the Friday, which is about 2 weeks, 13th, I think, of December, they're going to be doing a Christmas jumper day. So I suppose I would encourage everyone, you know, in your workplace, if you're going working, to go out and just wear a Christmas jumper, choose CF Ireland, you know, raise money towards that just by wearing, even if you're in school, you know, wear a Christmas jumper instead of your uniform for the day.
You can send a text or something, can you?
Yeah, you could text them. I suppose go on to cfireland.ie and find out more information. But that's for if you want to go out and I suppose support CFR, because they do loads of work in helping for people like me and people in the CF community. They do a lot of work for supporting us.
And there is expenses accrued by patients, isn't there? That obviously, if you were missing work or if you did need, extra physio and things, people do run up bills.
Exactly, and I suppose that's a great thing about Cystic Fibrosis Ireland is they have grants for patients with CF. So, for example, I've personally benefited from the exercise grant. So, I got a trampoline a few years ago, and CF Ireland helped pay towards that because, I suppose again with CF we have to do exercise. So paying, out of our own money, it does top up after a while. Even going to the gym, stuff like that, having to pay. So they helped, to pay for different grants that I suppose helped to improve our lives with CF, and so it's definitely worth looking
Good stuff. That's music to your ears, I'd say, Nicola.
Absolutely, and I'm
trampoline
delighted.
grants. It's good.
Yeah,
I mean, it is a great
yeah.
idea because it's something that
Exactly.
it's actually, when you think about it, it's kind of almost a perfect exercise.
Yeah, definitely. And I think Cystic Fibrosis Ireland are fantastic with the exercise grant scheme. It's open twice a year, so there's plenty of opportunity to avail of it. And with the patients that I've been speaking to, there was a host of patients that have actually benefited from the exercise grant scheme. So Cystic Fibrosis Ireland are doing fantastic work to promote exercise.
And there is good peer support there too, isn't it? So you can talk to other people with the condition and all of that. So there is a certain degree of being isolated if you have a chronic disease, and having friends who have the same thing, I think it is helpful.
No, definitely, and I suppose one thing with CF that not many people know about is cross-infection. So I'm actually not like if there's there was a CF patient beside me, there's a golden rule, and every CF patient themselves would know that you have to be at least 5, 6, 7 feet apart from another CF patient, because we're not allowed be near them, because we can pick up, say, the bacteria they cause. That, say, if I was beside you, for example, you wouldn't be able to get the bacteria I have in my lungs, but say it was someone with CF, I'd be able to catch what they have. So I suppose that's how social media has helped in that way, being able to, because we can never meet. So I suppose social media has helped to be able to talk to others and to be able to relate to with the condition, and to be able to just talk about, I suppose, things we go through our day-to-day life. And so social media has definitely helped like that.
Yeah.
But it's it is, I suppose
That's just, even when you describe it like that, I think, imagine any of us had to think about that when we meet somebody. I need to stand 6 or 7 feet from you. Those are things that are in your head that aren't in everyone else's head, because they're lucky enough to have an immune system that is that bit more robust, and that's hard. You're living with all those little restrictions. Exactly. Would anyone like to ask questions of our panel? We have obviously Bennett, who is an incredible young man and speaks so eloquently about living with it, and Nicola, who's so passionate about exercise, and then Porrick, who is like in the top 1% of immunologists in the world, in the room. For nerds like me, this is a bit like being starstruck, but would anyone like to ask a question? We would be delighted. Yes, this lady up here. Somebody will give you a mic there.
Hello, I'm a mother with a cystic fibrosis, 15-year-old actually. My first question is to Porrick. Porrick, very briefly, I know that Luke O'Neill's lab, and probably you involved as well, you've developed blockers for inflammation processes in rheumatoid arthritis. Are you kind of looking, or is there some of your science research applicable to decreasing inflammation in the lungs?
So Luke is the other one, the top 1%.
I know Luke well.
He's the top 0.0001%.
I sing in his band occasionally. I know him well.
So yeah, we've developed inhibitors. Luke's got some novel compounds that he's done in rheumatoid arthritis, lots of conditions. And what's happened is the realization that a drug company would develop a drug for, say, the lung. So you'd have this group of respiratory physicians, lung physiologists, lung immunologists, all working together for a drug for the lung. Now what happens is that you do a drug for the lung, and the realization that the pathway or the signaling, whatever that process is, that's abnormal, that compared to normal, is not unique to that lung, because cells are cells, and inflammation is everywhere. So whether it's in a bacterial-infected lung in a CF patient, compromised intestine, the common processes. So again, one of Luke's companies, they've tested in rheumatoid arthritis, some neurological conditions, and they'd be anti-inflammatories. So they affect inflammation. So any condition where that pathway has a role in the pathology contributes to the, again, CF would be specifically the lung damage or tissue lung damage, date of application. And CF specific, I don't know, is Luke involved? Actually, he's involved in everything. But definitely drugs that I've been involved in that the company were targeting a specific inflammatory bowel disease or asthma. Now they realize that that drug has utility for other conditions and other organs. So it's a big change that big activity to develop drugs for CF. There's a broad activity for inflammation where you're working on the guts or the skin, and you develop a drug and suddenly they join the dots and they literally realize actually that pathway is in normal lungs, and they say, oh, actually we've access to cells from patients with CF, we can test it. So great potential to develop.
So research in one area may have transferable uses to other areas, and that's all kind of coming hopefully soonish together, is that?
Yeah, I think you said earlier that for heart conditions, you're now given anti-inflammatories. There's one particular drug, so aspirin is one thing, but for heart conditions, there's a big famous clinical trial, and they blocked a specific protein. Now, I struggled 10 years when I heard this to join the dots, because that protein was for gout. Actually, it was developed for gout originally. It was a treatment for gout. And how do you give that for a cardiac condition? But they joined the dots, and it showed efficacy. So Luke and many others are developing anti-inflammatories for other conditions that could have utility for CF.
Well, I must say it's well needed, because the only go-to generally is steroids, and unfortunately steroids have detrimental effects to bone structures, etc. So that's why things like that. So get Luke and the team to keep working there. The other question is to Nicola. My son is really sporty by natural, and he's a tennis player and a rugby player. But he struggles with stamina. So after a 2.5-hour tennis match in the third and fourth set, he will then really, I can find, decrease. Now, maybe we might be switching to a vegan diet to try to improve that. But I do wonder, I know you're looking at just getting kids into exercise, but I know so many other CF kids who are competing like normal other kids. And so they're looking at bigger questions now about their muscle mass, about their stamina, etc. Are you going to look at more of that in the future?
Yeah, so initially our research is focusing on the kind of adult population, but definitely down the line we will be looking into introducing our program into children if it is effective in the adult population. But with regard to stamina, what we're trying to do is to develop a program that will, enable people to build it up, bout by bout. So you're kind of stressing the importance of not doing this 1 hour. You have to do 1 hour of physical activity. You can break it up into these bouts of, say, 10 minutes 6 times a day or 20 minutes 3 times a day to build your stamina, so that you're not, forcing yourself beyond your capabilities. And that's kind of what we're kind of leaning towards in our intervention, is to improve that.
Does he nebulize or anything before he goes out and plays a game? Is he doing stuff like that?
No, he's always been very naturally sporty, and he's played with the JCT last year, and he
Yeah.
competes.
Yeah.
Bennett and himself doing pickleball. But like that, we've always noticed that his muscles look particularly thinner, and that I often wonder, he does sometimes get salt issue, where
Yeah.
he will suffer because he's secreting so much salt and sweating so much in his competitive thing.
And do you use things like diorolite to rehydrate, or like practical things, like obviously lung function is increased immediately after nebulization and things like that?
Yeah,
So
that's a good question. So the team in Tala, actually knowing that he's a competitive person,
yeah,
competitive sports person, we did ask in Vincent's, and they did come back saying to him he's got to keep the diorolite with him.
yeah,
To keep him like that. They did want to put him on salt tablets, but that whole salt loss is a huge issue as well.
yeah. I guess practical management of it, because obviously I know what you're saying, Nicola, but it sounds like 20 minutes 6 times a day isn't what he wants. He wants to go out and play a game, doesn't he? He wants to go out and compete on a pitch. Yeah, he wants that. Yeah, exactly. I'm sure there are practical things like a nebulizer before the game. Sure. Of course. Yeah, good on them. Yeah. I'm sure it will stand to them all, the sport, no question. Is any work being done? You know, the DCU, the project they have out there, I think it's Moynihan. Niall Moynihan.
Yeah.
He does a huge amount of stuff about stamina and about physical prowess and all that sort of stuff. Is there any overlap between different, I suppose, health and physiology departments looking at this?
Niall's actually my supervisor.
There you go.
In our intervention, we are going to be looking at peripheral muscle weakness within the CF population, and that is a major manifestation of physical deconditioning. So we are going to test, so we're going to bring our participants in, and we're going to assess their physiological capacity and psychometric at the same time. But one of the tests that we're going to use is lower body strength, and we're going to develop the program as a result, because we're going to individualize each program. So we're going to develop the program as a result of their response to the strength test. So again, we're going to work on building peripheral muscle strength, and again, that's going to impact your aerobic capacity and your tolerance for exercise going forward.
Yeah, so it is kind of being looked at. I know
Yeah,
you wish these
absolutely.
things were quicker.
Yeah.
Every parent of anybody with any kind of condition wishes they were quicker, and I completely agree with you. Would anyone else like to ask a question? This gentleman here.
Hi, my question's for Nicola and then maybe for Bennett afterwards. So Bennett described his routine, his maintenance routine, nebulizers, chest physios, taking 3 hours, sometimes 5 if he's in a particularly bad state. Have there been any studies done on exercise routines, maintenance routines, reducing daily maintenance overall? That'd be my first question.
Yeah, so in relation to the actual drugs and therapies that are prescribed by the physicians and the MDT, exercise can't really take away from that. Like, that is the primary kind of path of care. But exercise kind of serves as an adjunct therapy. So it may reduce the amount of airway clearance that somebody might have to do. And it will also increase, your quality of life. So you'll have more vigor and be able to, complete your exercise regime or your treatment regime maybe faster or more effectively. But it will never take away from, the primary path of care.
Of course, but do you think it would reduce the overall maintenance time in a day? Like, would the person, if they were in better physical condition, or maybe Bennett could answer this even, do you feel after you've done your exercise or been particularly adherent to exercise, do you feel the time it takes during the day is less?
Yeah, well, I suppose exercise I see as a treatment, but I suppose it's kind of hard because loads of them are nebulizers, so I suppose you can't really, I suppose in the long term it could, help to reduce, I suppose, the amount of treatment I'd have to do, but I suppose on a day-to-day basis, exercise, I suppose, doesn't really cut back on anything. But again, I suppose the future doing exercise could build up to where they could say, look, you don't need to do this nebulizer, and then that could help to reduce time. But I suppose on a day-to-day basis, not really. It would be, hard to.
They're all kind of adjunct therapies, aren't they? You need this, and they're kind of building blocks, and it is very time-consuming, which is part of the downsides of having the condition, that a lot of your day is devoted to, I need to assign a block of time to do this. Like other people roll out of bed, pull on their clothes and go out the door. That's not a possibility really, is it?
No, not really. And again, I suppose for myself, I'm doing it, at least I know, I suppose if you have a good mentality on why you're doing it, then it's not really much of a problem. But yeah, we can't just, I wish we could, but we can't just get out of bed and just go over
You're
to
right
school
about having in your attitude is exactly right. Just get on with it, because otherwise it would, I think, be very wearing, and it
Definitely.
It could be. Does that answer your question? Would anyone else like to ask a question? Oh, well, there's a lady up the back, and then we'll come to you. There's a lady in black in the back row.
Another one one for Nicola. Is all of your research based on aerobic training, or do you do anything on weights and resistance?
Yeah, no, our program will incorporate aerobic resistance, flexibility. We're going to look at combined exercise as therapy, because there's been a systematic review was published in 2017, and it showed that aerobic training alone, resistance training alone, it doesn't have the same effect. And also those research studies were of very low quality. So what we're trying to do is trying to define and describe the best or the most optimal training program that's easily incorporated into daily life, but still captures the expert consensus guidelines.
And do you have any kind of feedback at this stage regarding weights and resistance, being a mother of a 19-year-old with CF?
Yeah, so we haven't actually started our intervention yet. That's due to start in February. But if you search a paper by the European CF Society, the author is Swisher. There's actually habitual physical activity, aerobic and resistance guidelines for the young child, the adolescent and the adult, and it breaks it down into each category and how much time should be spent, and the different limbs that should be worked and adaptations for different severities as well.
So someone could look that up?
Absolutely.
Will you say the name again?
Swisher, so it's Swisher.
How old is that?
It was published in 2016, I think, but it took years. It's kind of years in the making. So there's an exercise working group that is part of the European CF Society, and they're from all over the world, experts in their field, and they come together every year at the conference to develop these expert consensus guidelines. So that's what we're working off at the minute, and that's what we're kind of modelling our intervention off. But what we hope to do in the future, as I said, with the CPD course, my research team aim to kind of further precise, kind of make them more precise, and we want to use the experts in this country to kind of further develop the guidelines so that they are very specific for cystic fibrosis. So watch this space, hopefully.
Thank you. This
I just want to ask, with so many mutations of CF, is there ever going to be something that you can turn off the gene rather than managing CF, being able to cure CF without a transplant, with doing something with the actual genes?
Yeah, so that was heralded 30, 20 years ago.
Exactly.
Like actually not just CF, but many genetic diseases. The aspiration was that we'd actually target a gene and correct the deficiency or mutation.
Yeah.
And with some successes,
But
it's
there are
still,
thousands of mutations
Yeah.
now, aren't there? Yeah.
the issue is that yes, one size does not fit all.
I know, yeah.
It's simply one
That's what
size
I
fits all.
mean.
Yeah.
You couldn't possibly have a cure.
Yes,
You
correct.
might have a cure for one,
Correct.
but not for
Correct.
the 3,000 or whatever.
What I would say is that the new technologies that are developing, the CRISPR, the very rapid technologies,
Yeah.
are increasing the ability to manipulate genes with concerns of safety. I think that's the, my hesitancy earlier when Ciara asked the question about cure, which is not just aspiration. I think it's something we've got to aim for.
Yeah.
It's to manipulate a gene with the safety and like that. It is possible, but at this stage, with all the mutations, you might correct one mutation for certain patients. There's
That's
17
what I was meant. Yeah.
um,
There isn't a likelihood of a cure for CF with so many mutations.
I wouldn't say unlikely. Our current capabilities would suggest that there's a lot of work to be done, but other diseases where there's a single gene mutation, where there has been shown success, bodes well. So the technology has been developed for other genetic disorders. There's newer technology emerging. CF would be a difficult one to treat everybody, unless you actually target the entire gene, which is not the same as correcting a defect.
Is it possible, I think I know what you're asking, because so many mutations without being able to turn off the gene in its entirety, what are you going to do? But is it possible that through things like these new, I suppose, immune therapies, these powerful anti-inflammatories, that you could find a sort of a catch-all for nearly all mutations, because you'd actually be able to target the type of inflammation that is causing CF?
Yeah.
That's a possibility, isn't it?
Yeah.
And which would be a bit like a cure.
So gene editing to the actual gene itself, again, the question about the inflammation, if you've got a situation where you've other genes that affects lung function and you could target them, you'd have a combination therapy, a combination genetic therapy. Correct an individual gene with a complex gene is aspiration at this stage. Again, I can state situations where it will work, but
It's very early, isn't it, really in the development of...
yeah, no, there's lots of examples that are promising, but it just takes time. I think it's just literally technology is developed, and the Nobel Prize for Cancer was given out this year. That was like 25 years ago, and you go through the time to develop it, but that's been a success. Yeah, there is promise. There's definitely promise. Yeah.
But it's mainly in the management now.
Yeah.
It's the management of the condition, not necessarily the cause of the disease. So, the mutation causes a functional defect, a physiological defect that's complex, multi-system, and the focus probably be managing that. But in that, the multi-system, you'll actually have a approach where you target other parts of the condition. Yeah.
I know it's very hard if you're somebody who's a parent or a grandparent and nobody wants to hear those things. But even in the course of my career, we have seen groundbreaking changes, and we definitely have, and it is viewed differently. Are there more questions? Because I've thought of one I want to ask you guys before you go. Are there more? Just let me ask you one thing. We talked a lot about inflammation, and the lady up here who asked about her son was talking about a vegan diet, and there's a huge amount of talk in, I suppose, health talk about sugar and inflammation and diet and inflammation and those types of things. Do we know of any association with diet of any kind and having an ability to moderate the condition of CF? Do we know? Or is that not known? Is that an unknown?
There's probably stories out there.
There are stories out there.
Yeah, there are stories out there. The scientific evidence is emerging. Again, it's almost intuitive that even an abnormal diet or abnormal lifestyle with the exercise actually, it's not good for you. Modern living is not good for us, so there's all that complexity, and that's in a normal person. An individual with a complex disease will also be subject to too much sugar, lack of exercise, etc. In terms of an adjuvant therapy from exercise and altered diet, I can't give a specific that I'd actually advocate. Yeah. So
just be healthy anyway. Just have a healthy diet is what you're saying anyway.
I think Bennett described actually the effort that he goes through to have a normal life, which most young men would not do.
Yeah.
But it's the effort to have just a normal life. Yeah.
Okay. All right. Look, thank you. Thank you very much. Thank you all for coming this evening. Thank you most particularly to our panel, to Bennett Broderick, who is a CF campaigner, to Pádraig Fallon, Professor of Immunology, and to Nicola Hurley, PhD in physiology, in exercise as medicine, in all of this area. Thank you, all of you, for speaking today, and thank you all for coming and taking part.